Okay, let's get started. Thank you everyone for joining us. Today we have the pleasure of hearing from a visiting lecturer, Dr. Zoltan Arany. Dr. Arany is a Samuel Bellet Professor of Cardiology at the Perelman School of Medicine at the University of Pennsylvania. Dr. Arany's research lab studies the metabolic pathophysiology in the cardiovascular system using a variety of techniques spanning from molecular biology and numerous omics approaches to model organisms in human clinical trials. He has studied the role of vasculature in the development of diabetes and of maternal cardiac diseases during and after pregnancy, which we will hear about more today. Dr. Arany has been the recipient of several awards, including the AHA Established Investigator Award, the Hal Drovark Young Investigator Award in Translational Research, and the inaugural Yale Calabresi Prize, and has been well published in prominent journals, including the New England Journal of Medicine, Nature, Cell, PNAS, Cell Metabolism, and Genes and Development, to name a few. So at this time, I'll hand it over to Dr. Arany, and we look forward to any questions that you may have. Please put them in the Q&A box or in the chat.
All right. Thank you very much for that introduction. It's a real pleasure to be here. Thank you for inviting me. Wish I could be there in person. Everyone says that, but it's true. I have a very fond memories of being at UCSF in the past, and look forward to doing it again. So I will give you an update on our work on peripartum cardiomyopathy, which is something that we've been interested in for about a decade now. And you'll see how we got interested in it and some of the roadway that we've made as we've gone forward. Some of this will be published and some of it is about to be published. And I welcome questions during the talk or afterwards. Feel free to interrupt. Always a pleasure to be interactive at these talks, especially in the Zoom era when I can't see the faces, which is half the fun of giving a talk. So our lab is, oh, hold on, having problems advancing my slides here. Why is that? There we go. As you just heard, our lab is broadly interested in cardiovascular disease and in particular with a focus on metabolism and on blood vessels and the vasculature. So anything that intersects these broad topics is of interest to us. Today, I'll be largely talking about the intersection between cardiovascular disease and vascular disease in the context of maternal, of pregnancy and maternal health. So I always like to start with a vignette. This is a case that we presented a number of years ago now in the New England Journal of Medicine, and it's fairly typical. So this is a 40-year-old healthy woman. She's admitted 10 days postpartum after an uneventful pregnancy, healthy baby, nothing wrong during the pregnancy, no red flags. But she's admitted 10 days postpartum with shortness of breath. And that shortness of breath is exacerbated quickly when she presents in the emergency room. She has acute decompensation. She ends up being intubated to take care of her shortness of breath, which triggers profound hypotension. She's transferred to the intensive care unit. She's hypoxic. She has an intra-aortic balloon pump placed and has a bedside echo that reveals an ejection fraction of 11%. This is obviously a dramatic presentation. Not all cases present this way, but not an insignificant number of cases present this way. This is peripartum cardiomyopathy. It's sort of formally defined as a systolic heart failure with an ejection fraction of less than 45 in the last month or the first 5 months after delivery. In real life, it can present before that. It can present really at any time during pregnancy, although it usually presents postpartum, and it can present as late as a year after delivery, believe it or not. It's relatively uncommon, but it's not that uncommon. About 1 in 1,000 pregnancies worldwide. There's obviously a lot of pregnancies worldwide. So that adds up to a fair number of cases. And it's true everywhere around the world with some variation, which we can discuss if you're interested. It's actually a rising proportion of peripartum deaths in the United States. In most places in the United States, it's now the #1 cause of peripartum maternal mortality. And part of the reason for that is that it's probably on the rise. it's hard to know whether that's just because it's being diagnosed more or because it's happening more, but also because we're getting better at treating the other causes of maternal mortality, such as hemorrhage and hypertension and infection. These things have gotten better over the years. The cardiomyopathy has not gotten all that better over the years. So let me tell you a few things that we've learned in the last few years about peripartum cardiomyopathy before I tell you a little bit about the mechanisms involved that we've learned. And at the end, I'll talk a little bit about the genetics of peripartum cardiomyopathy. And hopefully there'll be time. I'll have a few slides on what I think are the implications for care of these unfortunate women. So as I said, you can have rather dramatic presentations, such as the case we saw. If you flip that statement around, it turns out that the vast majority of cases of cardiogenic shock that occur during pregnancy or shortly after pregnancy are peripartum cardiomyopathy. This was a study that we did a number of years ago using national inpatient sample databases. If you see a woman in cardiogenic shock who is either pregnant or recently delivered, then it's peripartum cardiomyopathy until proven otherwise, basically. Obviously, the diagnosis is echocardiography. And again, the diagnosis of peripartum cardiomyopathy is a systolic ejection fraction of less than 45 in the absence of known causes for that low EF. Obviously, if you started pregnancy with a low EF, that doesn't count. But until proven otherwise, it's peripartum cardiomyopathy. It's not an infrequent cause of transplant. So these women don't necessarily do all that well. Some do. Many don't. So it's not an infrequent cause of transplant. I like to show this slide. This is the UNOS website from a few years ago. You shouldn't believe everything you see in databases. I like to show this slide to make that point. It turns out that in that database, apparently 6 males had developed peripartum cardiomyopathy, which is a questionable piece of data. Nevertheless, for sure, it's a cause of transplant. We see plenty of them at University of Pennsylvania, and I'm sure that you see plenty of them too. There are a number of risk factors associated with PPCM. One is age, for sure, although you can have PPCM at any age. We've seen them in 16-year-olds, but it's certainly more frequent in older patients, such as the one I just presented to you. The second strongest risk factor is probably preeclampsia. Anywhere from 20 to, I would say, probably as many as half of patients with PPCM have some sort of gestational hypertension on board. Maybe not frank preeclampsia, but at the very least gestational hypertension. And this was really kind of buried in there in the literature for a long time. We did a meta-analysis almost 10 years ago that really sort of proved this point. Natalie Bello, when she was in my group, did this. So there's really no doubt about this fact. And I'll come back to this because I think this has pathophysiological relevance, that it's related to preeclampsia. Preeclampsia, of course, as I'm sure you know, is a common disease of pregnancy. Probably about 5% or thereabouts of all pregnancies have preeclampsia. High blood pressure associated with end organ damage, such as renal failure, most commonly. Again, as I said, a lot of women do okay, but a lot of women don't. So this is one example of that. There's many examples. So I like to show this one for a couple of reasons, as you'll see. This was a few years ago, a record of all cases in North Carolina over the span of 10 years, or 5 years, excuse me, looking at the cases of peripartum cardiomyopathy and their outcomes. And you can see two things. First of all, there's your 1 to 2,000 roughly prevalence or incidence of PPCM per live birth. So again, just like everywhere else in the world, ballpark. But you'll notice there's a profound difference between Black and white women. So it's far more common in Black women than it is in white women. I'll come back to that in a second. Not only that, but the Black women do much worse than the white women. So it's 4 times more common in Black women. And look at that. In this series, which is not that long ago, 25% of them were dead at 5 years. That's an incredible level of mortality. It's probably not that bad everywhere, not that profound everywhere, but just to make the point that this is a morbid disease. So as I said, it's far more pronounced in Black women than white women. And I think this is extremely important. And obviously this is a topic of great interest to everyone, especially over the last couple of years. But a Black woman is far more likely to die from pregnancy or childhood-related causes. And as I mentioned, this is one of the main causes of pregnancy or childbirth-related mortality. So it's much more common. Here's just a few sample reports of this. I won't walk you through them. The bottom line is that it's about 4-to-1 prevalence in Black versus white, as a consequence of which most of peripartum cardiomyopathy actually occurs in the South in the United States. We see it everywhere. We see it in Philadelphia. You see it at UCSF, I'm sure. But the vast majority actually occurs in the South, which is, of course, where the relative population of Black women is higher. So it's much more common in Black women. Here's our own experience at the University of Pennsylvania. This is work that we did just a few years ago. It was led by Corazon, who was a medical student at the time and is now an OB-GYN fellow, along with Mihail Elovitz and Lisa Levine. So it turns out that Pennsylvania, University of Pennsylvania is in Philadelphia, and Philadelphia is actually a very heterogeneous population, about 45 to 50% Black. So we have a lot of cases of peripartum cardiomyopathy. We have a large catchment area, and about 40% of them were in Black women. So it really afforded us a very good opportunity for looking carefully at the differences between races on outcomes. And the differences were pretty profound. So look over here, for example, this is the percentage of women who recovered, and we're defining recovery as achieving greater than 50% ejection fraction at some point. And you can see that 2/3 of white women recovered, but less than half of Black women recovered. And even when they did recover, if you compare the women that are in this red bar to the women that are in this blue bar, they recovered, but they took twice as long to recover. So this is a sort of Kaplan-Meier time course to recovery, and you can see white women recovered faster than Black women, and that's the ones that did recover, never mind the ones that did not recover. So there's markedly worse outcome, higher prevalence and worse outcome in Black women. And this is true in other places too. This has led us to ask the question of why that is. It's a really interesting question, and I don't have the answer to this, but I think it's a very important question. It turns out that one of the reasons is that they're diagnosed later. So this is time of diagnosis during pregnancy or immediately after pregnancy. 1 to 4 weeks, 1 to 5 months, or greater than 5 months. As you can see, look down at the bottom first. This is white women. White women are by and large diagnosed the first week after pregnancy. This is the classic presentation. It's the same one that I presented to you at the beginning. That's the classic presentation. Not so for Black women. Black women tend to present much, much later, sometimes months later. And when you do the subgroup analysis on this and you do the statistics, it turns out that the time of diagnosis is a better predictor of outcome than is race. So we think that potentially this is what's driving the racial differences. So that still begs the question of whether there's something inherent about race that is causing the later presentation, or the later presentation is a consequence of something non-racial or socioeconomic aspect of race. We were interested in that question. So most recently, we teamed up with Richard Aplink at Children's Hospital of Philadelphia and Kelly Getz. And all this work has been done with Jen Louie, who runs our maternal cardiovascular complication clinic. And we used geocoding, sort of block level geocoding information to try to correlate outcomes to socioeconomic status. And I won't go through the details. This paper just got published. You can look at the details. But the bottom line is that, not surprisingly, socioeconomic index correlates. So the worse your socioeconomic index is, the worse your outcome is. That's not a surprise. But I think what's important is that when you control for all the variables, this is, again, a better predictor than race is. So we think that this likely explains a lot of the racial differences. And in particular, it turned out that education was the best marker for predictors of outcome. And that, I think, has hugely important implications, because it means that education outreach should have an impact on outcomes here. There's obviously not much we can do about race as a genetic concept, but there's a lot we can do about race as a socioeconomic and social construct. So I think there's an opportunity here, which we're trying to figure out currently how to implement. So that's kind of a primer on some of the clinical aspects of peripartum cardiomyopathy. So again, as a reminder, the prominent risk factors are age, race, and preeclampsia. And this is a disease that I consider fairly morbid, about which we still don't know a lot. What do we know about it in terms of mechanism, in terms of how it happens? What causes peripartum cardiomyopathy? This was the question that actually got me interested in this disease in the first place, as you'll see in a minute. I'm going to pose to you the sort of completely silly and obvious hypothesis that there's two components to this. There's pregnancy and there's something else. So obviously, peripartum cardiomyopathy is caused by pregnancy. And there's something else because not all pregnant women develop this disease. So let me just talk about these two things separately. So what is it about pregnancy that could be causing cardiac dysfunction? I think if you read textbooks from 20 years ago, they'll tell you that it has something to do with the hemodynamic stress of pregnancy. And there's no doubt that that pregnancy is a hemodynamic stress on mom. Cardiac output goes up by about 40% during pregnancy. And that's largely as a consequence of increased blood volume, but also as a consequence of increased heart rate and consequently and stroke volume from the large blood volume as well. So there's definitely the heart, mom's heart is working harder during pregnancy. But you'll notice that the onset of all these hemodynamic changes really occurs at the end of the first trimester and the beginning of the second trimester. But the disease, as I told you, by and large presents postpartum. So the timing is not quite right for this being the trigger of peripartum cardiomyopathy. And I've always doubted that this is the true trigger of peripartum cardiomyopathy. So it begs the question of, if this is when the disease is presenting, then what is it that's happening in late pregnancy or early postpartum that could be triggering this disease? Because that's when it presents. And the answer is obvious. The answer is hormones. The hormonal changes that occur at late gestation and early postpartum in mom are profound and tremendous. In many ways, any points beyond development and growing into an adult, this is the most profound changes that occur in the fastest way in human beings. I would argue is mom during immediately postpartum. There are tremendous numbers of hormones, as you know, of course, from the pituitary, such as prolactin. I'll talk about that in a minute, that are involved in reprogramming mom from essentially carrying a fetus inside of her to now supporting a newborn outside of her. The logistics of those two things are completely different, and the fetus has learned to reprogram mom to service both of those purposes and to change from the one to the other extremely quickly, over the span of hours. And a lot of that is driven not just by the pituitary, but by the placenta. So it turns out the placenta is really the largest hormonal organ in the body. It just happens to be transient. But we've done, and I won't show you this, but we've done, for example, plasma proteomics on pregnant women compared to post-pregnant women, and the differences are tremendous. Most proteins actually change. Circulating proteins change between non-pregnant and pregnant and immediately post-pregnant state. So there's a tremendous reprogramming of mom, and we think that these hormones are actually what is triggering peripartum cardiomyopathy. And I'll give you the two most prominent examples that we know of and that we have worked on. The first one was discovered about 10 plus years ago now by the lab of Helmut Drexler, who's now deceased, along with Denise Hilfricke-Kleiner in Germany. And I won't walk you through the data. You probably would start yawning if I showed you all the mouse data and all of that. So trust me that the data is pretty solid for this model, at least in mice. And I'll come back to the clinical context in a minute. But what we think happens, what they showed, and we have data to support this as well, is that in the immediate postpartum period, prolactin gets activated from the pituitary, of course, because mom is now expected to lactate, and that prolactin drives that lactation. And what happens is that under certain circumstances, the heart secretes peptidases such as catepsin D, which cleave prolactin into a small prolactin piece, a 16 kilodalton piece, which actually has been studied for decades and is known to be vasculotoxic. And so this vasculotoxic piece of prolactin causes damage to the endothelial cell to the endothelium of the heart, leads to endothelial apoptosis, and basically leads to global ischemia in the heart. And the heart becomes globally ischemic, as a consequence of which it triggers downstream effects such as apoptosis and develops cardiomyopathy. So there's something about this high secretion of cathepsin D that in some women, or at least in some mice anyway, triggers this to happen. So the bottom line here, just conceptually, is that a hormone is causing vascular dysfunction in a model of peripartum cardiomyopathy. This very same concept is what we stumbled upon a few years ago in a slightly different context, but it's the same notion that a hormone is triggering vascular dysfunction. In this case, the hormone is different. Now it's not coming out of the pituitary, now it's coming out of the placenta. And the hormone is soluble FLT1, which you may have heard before. This is all work. Ian Patton was the research assistant in my lab who led this work. And this is all done collaboratively with Anant Karamanchi, who's a really world leader in thinking about preeclampsia, and you'll see in a second why that's the case. So soluble FLT, it turns out, is normally secreted by the placenta. It's a completely normal process. Every late gestational woman has tremendously high levels of soluble FLT in her plasma. This is a normal thing. Soluble FLT is a receptor for vascular endothelial growth factor. FLT is a receptor for vascular endothelial growth factor. So when this is one of the ways in which vascular endothelial growth factor, which is a pro-vascular health hormone, this is one of the ways that it regulates, that it promotes that vascular health. Soluble FLT is basically just the sort of soluble part of that, the extracellular part of that receptor. So what happens when you have high circulating levels of soluble FLT is that it sops up the VEGF. And now the VEGF can't act on where it wants to act, which is on the endothelium, to keep it healthy and happy. And the consequence of which is, just as in the previous slide, is an unhappy endothelium. So in late gestation, again, this is normal gestation. In normal gestation, there is an anti-vascular context because of all this solute floating around. And we think that it predisposes a late gestational heart to becoming ischemic because it has fewer defenses against ischemic insults. And this is actually accentuated in preeclampsia, dramatically so. This is probably the best biomarker for preeclampsia. It's much induced, sometimes 10 to even 100-fold in late preeclampsia. So you can imagine how much of an insult that is to the cardiac vasculature, as well as the rest of the body, of course, but we're focused on the cardiac vasculature here. So it's a tremendously stressed moment from a vascular point of view, and it doesn't take much to tip that over into peripartum cardiomyopathy. So I'm sparing you the details of the mouse models, et cetera, that led us to all of this. What I'll give you is some of the clinical data that I think supports this. So if this is right, if this soluble FLT being secreted out of the placenta is causing vascular toxicity and creating an environment in which it is easy to tip over into peripartum cardiomyopathy, then there's some predictions that should be true. The one of them is that, at least in mice, we should be able to prove that we could give soluble FLT and cause cardiomyopathy. And again, I won't show you that data because I decided I wasn't going to show you any mouse data. But yes, I assure you that we can reproduce this in the right mouse model. Of course, we would like to do this in people, but we can't do it in people. We're not going to go inject soluble FLT in people. But as I told you, in some sense, that's what preeclampsia is. There should be preeclampsia should predispose to peripartum cardiomyopathy if this is right. And as I showed you a few slides ago, that's exactly the case. I'll show you the slide again in a minute. So are women predisposed, with preeclampsia at risk of peripartum cardiomyopathy? For that matter, even if they don't tip over into peripartum cardiomyopathy, do women with preeclampsia who have a lot of soluble FLT floating around, do they have evidence of cardiac dysfunction? Even if they don't go all the way into PPCM, is there evidence of cardiac dysfunction? This was an interesting question that we thought would be predicted by this model. And then conversely, can we see evidence of soluble FLT being elevated in peripartum cardiomyopathy? So let me just walk you through 3 slides to just show you that these answers are correct. So I already showed you this slide. again, work of Natalie Bello. This has been reproduced now by many labs, and every cohort pretty much of peripartum cardiomyopathy shows this. So there's clearly a very strong relationship between gestational hypertension and PPCM. And I would argue that it may well all be explained by elevations in soluble FLT, perhaps other placental-derived vasculotoxic factors. So the answer there is decidedly yes. So do women with preeclampsia have, even when they don't have peripartum cardiomyopathy, do they have evidence of cardiac dysfunction? This has now become clearly also the case by multiple groups. But this is one of the earliest studies that we did collaboratively with Sarosh Rana and Sajid Rahul, who are currently now at the in Chicago. This is, so now we're looking at more subtle indices of cardiac dysfunction. We're not looking at ejection fraction. We're looking at longitudinal strain by speckle patterning. And it is clear that women with preeclampsia, and actually this persists for a significant amount of time. I'm not showing you that here, but it'll persist for even a year after delivery. There's clearly evidence in women with preeclampsia of sustained cardiac dysfunction as measured by aberrant speckle pattern longitudinal strain on echocardiography. Moreover, that dysfunction correlates with the level of soluble FLT that they were exposed to during pregnancy. So again, evidence in humans for that soluble FLT to be damaging to the vasculature and to cardiac function. And then the last question is, of those three questions, is soluble FLT elevated in peripartum cardiomyopathy? And the answer is yes, it is. We worked with Dennis McNamara to do this. So Dennis is at the University of Pittsburgh and has worked for many years on this topic and has created a cohort of prospective cohort of 100 women from across the United States called the IPAC group of 100 women with peripartum cardiomyopathy, started following them in the acute stage and then followed them for a year. This has been a wealth of well-curated information about the natural history of peripartum cardiomyopathy. So we looked at soluble FLT levels, and indeed they were elevated. And not only that, but the soluble FLT level at presentation correlated with the NYHA class of heart failure and correlated with event-free or inversely with event-free survival. In other words, the highest the soluble FLT, the lower the event-free survival was, defined as death or LVAD amongst these 100 women. So there's clearly a relationship between soluble FLT and peripartum cardiomyopathy and outcomes of peripartum. So this is still an incomplete picture, but it is a far more complete picture than it was 10 years ago when we communally with largely Denise Hilfiger-Kleiner's group started looking at this. The model, again, to just sort of hash it one more time, is that late gestation is a hormonally dynamic period. And during that time, there are hormones that are coming out of the pituitary and hormones that are coming out of the placenta that are vasculotoxic, and they are predisposing the heart to global ischemia and cardiomyopathy under the right context. And some of these are markedly elevated in preeclampsia, likely explaining the epidemiological correlation between preeclampsia and peripartum cardiomyopathy. So that's how we think, at least part of the mechanism of how peripartum cardiomyopathy occurs is happening. That's the pregnancy part of how this is happening. But obviously, as I said, every woman in late gestation, normal late gestation, is exposed to these antivascular agents, and even more so in preeclampsia. But the vast majority of women, even with preeclampsia, don't develop peripartum cardiomyopathy. So clearly there has to be something else. There has to be another hit, if you will, to develop PPCM in the face of these insults. And that has led us to the question of whether there could be a genetic component. When you see a disease that's only 1 in 1,000, you invariably think about potential genetics. There's a number of reasons why we could think about genetics in PPCM. I think some of them valid and some of them perhaps not so valid. It's a rare disease, even though pregnancy is common. So there's something, an extra hit there, as I mentioned. It's, as I mentioned, more frequent in women of African ancestry. Now, I don't know whether this is a social economic reason or whether this is an actual genetic reason. And that's remains open for debate. But it does make one think, at least, of genetics. There are definitely geographic hotspots, which I didn't mention, which make also potentially one think of this. For example, in Haiti, the incidence of PPCM is as much as 1 in 300. In parts of Nigeria, it's actually as much as 1 in 100. So it's extremely common in some places. Again, hard to know whether that's truly genetic or not. There was one GWAS that identified a single locus in PTH-LH, but that has not been reproduced by other groups, so I'm not 100% sure that's turned out to be true. There definitely have been sporadic reports of familial clustering. From the very beginning of the description of this disease in the early 1900s, people have noticed that it can travel in families. That, again, you can't prove that it's genetic. It could be something about the familial context, but nevertheless, it does make you think about this. And there have been a few reports of rare pedigrees in the literature. So a number of years ago, we addressed this question, and we started to address this question first by collating samples from, basically colleagues and friends from around the world. We ended up having at that time 172 samples of PPCM. 40% of them were Black, mostly from the United States. And we worked with John and Cricket Seidman, who most of you have probably heard of, so preeminent cardiovascular geneticists at the Brigham and Women's Hospital and at Harvard. And we worked with them to sequence, and I'll show you in a minute how we do this, to sequence about 60 to 70 potentially causal genes that are thought to potentially contribute to dilated cardiomyopathy. And now we're asking what's going on in peripartum cardiomyopathy. So why did we choose those genes? Because phenotypically, PPCM and dilated cardiomyopathy are very similar. Even though the one occurs in young women and the other one typically occurs in middle-aged, both men and women, phenotypically, when you look on the echocardiogram, you can't tell the difference. Right? They're both tend to be dilated and they're both low systolic ejection fraction, and I didn't show you pictures, but they both tend to involve both the left ventricle and the right ventricle, and they do it globally. So there's phenotypic overlap between the two. Actually, the reason I did this in the very first place is because I thought they would be different, PPCM and DCM genetically. It turns out that that's not true, as you'll see in a minute. So what we found at that time is that of those 172 cases, 17 of them had a loss of function variant in the gene titin, which encodes for the gene TTN, which encodes for titin. Titin is the largest protein in the human body. It spans half the sarcomere, all the way from the Z line to the M line. It is, in some ways, is the rubber band that holds the sarcomere together. And the sarcomere, of course, as you know, is the engine that drives contraction in the heart. So you can imagine how mutations in this might cause disease, although I'll get back to this if I have time at the end. I think we actually don't know how this is working. But there's no doubt that this prevalence is higher here. The prevalence in the population is probably about 0.5%, maybe 1%. So there's an odds ratio of 10 to 20 here with p-values that are extremely strong. So there's a high prevalence of titin variants. So I consider this study to be a preliminary study, honestly, and it answered questions, but insufficiently answered the questions that we wanted to address. The first and foremost, the question was, what percentage of PPCM is genetic? Here we found 10, maybe 15% variance. I think that's the tip of the iceberg. We wanted to know more. And then what genes are affected? We clearly saw titin, but we didn't have the power to see if there were more. We saw more, but we couldn't say with statistical confidence that they were overrepresented compared to a general population. And then does this help us in clinical care? We didn't really have good clinical annotations with these 172 patients. So I couldn't tell you, for example, does the presence of a titin variant mean that your prognosis is worse? I couldn't tell you that from that data. So we needed more numbers and we needed clinical data. And so let me tell you in a couple of slides work that ended up being finished and published by your very own Rahul, who's I suspect listening in. So over the last few years, we set up we continued to gather samples from around the world with help from wonderful collaborators from pretty much across the globe. And we ended up with almost 500 well-curated, well-sequenced patients with peripartum cardiomyopathy, along with clinical data to go with it. And so we were able to ask these questions. Lots from the US, lots not from the US. I'll skip this table for the sake of time, but the bottom line is that we have them from everywhere. And then again, we did the same thing. We focused on just 60 what we call DCM genes, which is basically the panel that you get when you're sending clinically, when you send for genetic testing for DCM. In essence, it's that panel. It's the same thing. And for those of you who don't know, what you're basically doing when you do this is you're shearing whole genome DNA, and you're attaching it to a filter that contains just your 60 genes of interest, and you wash away the rest and just sequence what's left. So you're sequencing 0.01% of the genome, which turns out to be obviously much more doable and cheaper. Nowadays, of course, things are cheaper, but remember, this is a few years ago. So we sequence it, and then we look for truncating variants. So what do we mean by truncating variants? We mean nonsense or frame shift or splice site alteration. So these are mutations that are going to basically cause a protein to stop being made and truncate that protein. And the reason we do that is because we have high confidence that that's going to damage the protein. If you look for missense variants, you will find so many missense variants that you don't have the power to tell the difference between, it's drowned out by the noise of inconsequential missense variants. There's so many inconsequential. So this is statistically, we're forced to look under this lamppost. But importantly, that means we may be missing a lot of things. In any case, we do that. We look for truncating variants, and then we compare it to a reference population, in this case, NOMAD. And we found a lot of things with high confidence. Let me show you a few examples. So Titan again, right? So Titan, we found 49 variants in those 600. So that's a prevalence of over 10%, just like we did last time. So that's comforting. We see the same thing. Now the p-value is 10 to the minus 48, nothing to scoff at. So we find Titan, but we find new things and with significance. Filament C, you may have heard of, is in dilated cardiomyopathy as well. We saw a bunch of, a number of these variants. Desmoplakin as well, involved in no longer a sarcomeric protein, but still involved in sort of cellular integrity. And BAG3, which is involved in autophagy and protein quality control. And then a number of other ones that didn't quite reach significance, but I suspect are probably real. So there's a few things that are pretty interesting about these findings. So we find sarcomeric proteins, but we find non-sarcomeric proteins. At least a couple of these, and I'll come back to this, are associated with high arrhythmia risk. So I think it's pretty relevant to find this in a woman. It will change your management if you find this in a woman. So I think that's important. And then the other thing that's quite interesting is that we see them with different prevalences, right? Ranging from a high of 10% to 1%, and a low of 0.2%. And that prevalence, that frequency with which we find these mutations is almost identically the same as the frequency with which they show up in cohorts of dilated cardiomyopathy. So these are cohorts of older, both men and women, who present very differently, but end up having, by echo, a similar disease. And it turns out that the genetic predisposition appears to be identical. I think that's a really important observation. Right? The genetic predisposition to heart failure is obviously an important risk factor for both PPCM and DCM, and it suggests common pathogenesis. Somehow the insults that are causing PPCM and the insults that are causing DCM must have things in common, because they're triggering the disease at the same frequency given the underlying genetic predisposition. So to me, this was fundamentally the most important observation from Rahul's study. Remember, I wanted to ask the question of whether we could now make clinical predictions based on these these genetic findings, and we were surprised that the answers seemed to be no. We focused on the Titan truncating variants because they're the most abundant in our genetic findings, and it turns out that, so this is with truncating variant, and this is without truncating variant. Everybody has PPCM here. It turns out that they tend to present with lower ejection fraction, but if you come back a year later, their recovery rate is nearly identical, half to 2/3 recover, whether you have a truncating variant or you don't have a truncating variant. So there doesn't seem to be prognostic value to this particular genetic test, at least on this particular front. This is actually, interestingly, is pretty much what people are seeing in dilated. Sorry, I'll make that point in a second. It's very similar to dilated cardiomyopathy. It looks like in DCM, truncating variants in Titan also tend to present with a lower EF, and they may actually have a slightly better prognosis. So we're actually sort of seeing the same thing. The other thing that's interesting that I just want to make the point of, in our original New England Journal, we did some post hoc analysis of the few numbers where we had clinical information, and it looked like we could make prognosis from that. But it was small numbers, and it was post hoc, and it was wrong. The message being, don't trust small post hoc analyses. We ourselves sort of fell into that trap. Okay, so now coming back to these questions, I think we've learned more. We still have more to learn, but we've learned more. We still are identifying about 15%. There's probably more. We looked under the lamppost. We've only looked at 60 genes, and we've only looked at loss of function variants. I suspect there is more, and we're moving forward to try to do more. We now know quite a few more genes that are involved. Filament C, desmoplakin, BAC3, probably the MYHs. I suspect there'll be more. So we have more work to do here. And does the knowledge help us in clinical care? I've given you a couple of hints as to why I think it might. It's open for discussion. I'll come back to it in a few slides. I think I still have time. Yeah, still have a few minutes. Back to the two-hit hypothesis, right? You have to be pregnant, and then there's something else, and maybe a genetic predisposition. So how do these Titan truncating variants cause disease? This has been a question of great interest to us, and I'll fly through a few slides. This is now for the more basic scientists in the audience. So if you're a true clinician and nothing else, now is a good time to get a cup of coffee. The bottom line is that I still don't know, honestly. But going back to this number, right? So I told you that 10, maybe more % of cases of PPCM have truncating variants in Titan, and that was an odds ratio of 10 to 20. The reference population, therefore, has about 1% prevalence of TTN truncating variants. That's high. That's really high, right? It's not the case that 1% of the population is walking around with dilated cardiomyopathy or peripartum cardiomyopathy. Right? It turns out that these things are not very penetrant. There's a couple of reasons for that. One of them is that there's a huge chunk of Titan that is actually not expressed in adult heart. So this is the way to read this somewhat complicated graph is, here's the protein, right? There's Titan. And every blue line that you see here is an exon. So Titan has 364 exons, hugely complicated protein. And what's interesting is that the middle 100 or so exons are typically not expressed in the adult. So you can imagine that if you have a truncating variant in a not expressed exon, that makes no difference whatsoever. So, and in fact, that's the case. When you look at the cohorts of DCM or you look at the cohorts of PPCM, and you ask where are the truncating variants that are found in these patients with disease, all those truncating variants are found in what we call high percentage spliced-in exons. They're all found in exons that are expressed in the adult. So that makes sense. So it turns out that probably sort of gets rid of about half of your burden compared to the population. But it's still a pretty high burden in the population. So not all loss of functions variants are pathogenic because of that. But it turns out that even if you just focus your attention on those exons that are expressed in adults, most people don't have disease. You can't just look at a database like NOMAD and know this because NOMAD doesn't have associated clinical information. So we collaborated with the Geisinger group in northeastern Pennsylvania that really has a catchment of millions of patients. And they have been sequencing a lot of these patients somewhat indiscriminately, really, just sort of whoever they could enroll. They have about, when we did this, they had about 60,000 whole exome sequence. But of course, these are linked to their electronic health records. So we know a lot about these people. These are not people with disease. These are just people in their catchment. 0.5% of these should have truncating variants if we're right, and that's exactly what we found. We found 300 cases that had truncating variant in an exon that is highly expressed in the adult. So the question is, how many of these people have dilated cardiomyopathy? The answer is a tiny fraction, less than 5%, had any sort of cardiac diagnosis. And the other thing that's interesting is, nowadays it's a little bit like CT scans. When you come to the emergency room or to see your doctor, they get an echo. Why not? So it turns out that a lot of these people had echoes. What did their echoes look like? Their echoes look normal. So greater than 90% of these people have normal echoes, despite the fact that they have truncating titan variants. So we don't understand why the penetrance is low, but it's low. It means that there's something else. There's other insults that have to trigger this disease. Maybe pregnancy is one, of course, that's part of it. But it turns out that there's other insults that are associated with titan truncating variant disease. Oncotherapy is one, and we were fortunate enough to be part of a study published recently by Bonnie Kai that showed this to be the case. So having a titan truncating variant predisposes you to oncotherapy-induced cardiotoxicity. And the same is true of alcohol-induced toxicity, shown by James Ware and others in England. So the picture is more complicated, but certainly, that makes it interesting. Probably there are other hits. Probably they're cumulative. Things to think about. So let me see, how am I doing for time? I want to leave 5 minutes for questions later. So I'm going to skip the hardcore biochemistry here. Let me just skip a few slides here and just sort of go to the conclusion in the clinical implications. So what have we learned about PPCM in the last 10 years? Because I think we didn't know much 10 years ago, and I think we've learned a lot in the last 10 years. I think we've learned that PPCM is a vascular hormonal disease. It's caused by hormones of late gestation coming out of the pituitary, coming out of the placenta, and they're causing vascular toxicity, and that's what's triggering the disease. This is marked by synergy with preeclampsia because preeclampsia makes this worse. I think we've learned that there's a significant component of genetic predisposition to this disease, certainly titin, but other genes as well. But the mutations are not very penetrant. Certainly titin is not very penetrant. So there are other hits that we still don't understand and need to understand. I come back to this point. There are profound racial disparities in outcomes and in prevalence of this disease. And I think that the evidence so far suggests that socioeconomic status has a lot to do with it. And I think this is a good thing in a sense because it's an opportunity for intervention, and we should think hard about how to do that. And I still don't understand how titin and other variants cause PPCM. This is what I think a lot about late in the evening. Happy to discuss more about that. So just a couple more slides. How does this help us managing patients with peripartum cardiomyopathy? So fundamentally, not that much different from treating somebody with dilated cardiomyopathy. You do the same usual thing of treating preload and afterload and intervening as much as you can with neurohormonal, aberrant neurohormonal response. ACE inhibitors, ARBs, beta blockers, all the same. Obviously, you have to be a little careful during pregnancy with what you can or cannot do during pregnancy. But again, usually most of these patients present postpartum, so you have no limitations. I told you some of these patients do not so great, and they are treated just the same way. Inotropes, balloon pumps, Impellas, LVADs, ECMOs. We have used all of these, as I'm sure you have, and it's really not that different than dilated cardiomyopathy. If you do see a patient during pregnancy, there's really no indication to do early delivery unless you have to. But there's no PPCM specific indication to do either early delivery or C-section. There's no evidence that either of these things improves outcomes. Obviously, if you're unstable, you're going to do it. But there are a few sort of special things to think about, which I'll do in the next 3 minutes. So a couple of them are AICDs, right? Implantable cardioverters. Normally, you would do that for somebody with an ejection fraction of less than 35. But here, you should be careful about that because a lot of these women recover. More than half women recover, certainly white women anyway. And so I would say the practice right now is to consider putting a jacket instead and monitoring for a few months to see if you get recovery. And then if you don't, then of course consider putting a permanent AICD. Transplant is inevitably what you have to do if you have to do it. The problem is that women with PPCM reject their transplant more, and that should probably go into the equation. Probably the reason is that they're young and healthy and have better immune systems, but we don't really know why that's the case, but they have more rejection. And then anticoagulation is an important point too. So the peripartum period, up to weeks after delivery, is a particularly hypercoagulable period. So if you have a low EF and are hypercoagulable, you're at extremely high risk, and the rates of strokes are not small in these women. So the threshold to anticoagulate should be really low. That is a special case, a special consideration in this case. Can your patient have another pregnancy? This is a question we get all the time. And unfortunately, we don't have a good answer. There's not a lot of data out there. This is one study. There's a few more, but I'm just showing you the one because it was the first one from Uri Al-Khayyam in Los Angeles. He basically looked at women, divided women into whether they had recovered their ejection fraction to over 50 after their case of peripartum cardiomyopathy versus ones who did not, and then went on to have a subsequent pregnancy. And the answer was that of the ones who had not recovered, 3 died, and of the ones who had recovered, none died. So that tells you, if you haven't recovered, you're in trouble. But the fact of the matter is that all the women, nearly all the women, reduced their ejection fraction on the second pregnancy. It's just that not all of them then went on to have dramatic and adverse outcomes. But in any case, other studies sort of look like this, and currently these sort of loose recommendations are: if your EF has returned to normal, then go ahead and have another pregnancy. But if it has not, it has not. I think this is a soft recommendation. It should be taken on a case-by-case basis, and in either way, you have to have very close monitoring of the pregnancy, and we can talk more about that. A couple more points. Should your patient take bromocriptine? This has become a very controversial issue. Remember, the idea is that prolactin, which is coming out of the pituitary, is causing vascular toxicity in the peripartum period. That means that you should be able to prevent this from happening by preventing prolactin from being secreted. And we know how to do that. Bromocriptine is an inhibitor of prolactin secretion from the pituitary. It's been used clinically for a long time for other indications. And I can tell you that in mice, this works in all the models that we've tried. So it works. So should women take it clinically? Well, that was tried in a small randomized trial about 10 years ago, only 20 women. It was placebo controlled, but it was open label. It was in one center, very small numbers. And a very dramatic improvement by bromocriptine, but this very small study, and it's gotten a lot of pushback because 40% of the control arm died, and that's a very high number. That's just a weirdly high number. So this needed a better study. The group in Germany tried to do a better study. Unfortunately, their sort of IRB equivalents would not let them have a placebo arm because they felt like this data was enough to say that everyone should be on bromocriptine and you can't withhold bromocriptine. So they wouldn't let them have a placebo arm. So they had a 1 week versus 8 week of bromocriptine, and it was a wash. No difference between the two. So that's just not helpful. So I can tell you that in Europe, bromocriptine is used a lot. In the United States, bromocriptine is used very rarely. And I don't know who's right. I think the jury is still out. Dennis McNamara has now expanded the IPAC group, and he is about to begin, or hopefully has even begun, again, a multi-center, now placebo-controlled randomized trial of bromocriptine in 200 women. And I think this will answer the question definitively, and I can't wait to see the answer. But for now, I can tell you that we tend to use bromocriptine in women who are really sick because why not? There are some downsides to using bromocriptine, and we can talk about that. But we're kind of almost out of time. So the same question applies to nursing. Can your patient nurse? And basically, there's very little data. I won't walk you through it, but there's very little data to support that women should not nurse, despite the fact that it's logical. There's just very little clinical data to say this, to support this. And you got to weigh the benefits to the baby here. right? Not nursing has an impact on the baby, especially in third world nations or in socioeconomic disadvantaged contexts. So that's critically important. And then the last thing is, should you order genetic testing? And I would argue that you should. And I think the reasons are twofold. One is, if you find those cases of filament C or desmoplakin mutations that have a high arrhythmic risk, you're going to have a lower threshold to be preventive on that front. And I think that's important. And then the other thing is, it affords the opportunity to cascade tests and provide reassurance to, for example, your patient's sister who wants to have a child, and you can tell her sister, you don't have this mutation. And I think that has value. And certainly in the world of dilated cardiomyopathy, the current recommendations are to do genetic testing. And I just told you that I think DCM and PPCM are genetically, as far as I can tell, identical. So if we're going to recommend it in the one, we should recommend it in the other. That's my own personal feeling. So I'll stop there because I'm out of time. If you're going to take two things from this, one is, we think this is a hormonal and vascular disease. And two, there's a strong genetic component. I think these things have implications for management. And I'll stop there. Our patient did okay. I'll skip for time to show you our lab, only because I've been showing pictures like this for a while, and now I'm really happy to start showing pictures like this again. And thanks for your attention, and I'll take questions. Appreciate it.
Thank you, Dr. Arany. That was an amazing talk. I have a number of really great questions. I'm going to have Dr. Mosley ask his question. Can you hear us?
Yes.
Perfect.
Hey, Javid.
I don't know if hi. It's my first week here, so I don't know how to show my video. I even changed my background.
That's all right. I know what you look like.
So two quick questions. One is, what do you think is the mechanism? First of all, great talk, really good. What do you think is the mechanism by which soluble FLT1 causes cardiomyopathy? Is it simplistically thinking it could be microvascular dysfunction? And if so, what are the long-term effects, if any?
Oops.
I think I might have.
Oh, you muted him.
There we go. Now we have the video.
Now, here we go. It's a picture I took. So.
Oh, nice.
So I guess the first question is, how does soluble FLT1 cause cardiomyopathy? Is it simply microvascular rarefaction? And what are the long-term issues with this? And the second question is, playing devil's advocate, it seems like Titin mutations are associated with many forms of cardiomyopathy, especially dilated cardiomyopathy. And the simplistic way is saying, well, the heart's not working 100%. You come with a second hit, whether it's a cardiotoxic therapy. Is there a type of cardiomyopathy that's specifically not associated with Titin, arguing mutations, suggesting it's a specific to, there's something specific pathophysiologically? So I guess those are the two questions.
Yeah. Both really interesting questions. So soluble FLT, nothing in biology is ever simple. So I can tell you the answer is no, it's not simply that, but that's a cop-out. Our data supports the notion that it is a vasculotoxic, vascular dropout leading to ischemia. So if we look in the mice, for example, after we treat them with soluble FLT, they have vascular dropout. They have fewer blood vessels after pregnancy in their heart. And they have, and we can put them in the PET scanners and show that they have decreased blood flow, coronary blood flow. So it's certainly consistent with that model, and we can rescue them by giving the VEGF back. So it's certainly consistent with that. Now, are there other things going on? Probably.
Do these persist? Because that could have
so that's a great question,
for...
right? So we haven't done a lot of long-term studies in the mice, but certainly, women with preeclampsia have long-term complications, decades later complications. And you can ask the question of, is that because the preeclamptic episode caused irreversible damage that manifests itself 20 years later? Or is it because there's underlying risks that are predisposing you to both the preeclampsia and I think the jury on that is still out. Although there's been some studies, including some of my favorite studies by Iris Jaffe, whom you know, along with Ananth, where they've taken rat models and mouse models and given the soluble FLT transiently to mimic pregnancy, and then let the soluble FLT levels go back to down, and then come back 2 months later. And the ones who got soluble FLT have CMT. They have thickening of the carotid arteries, as if the soluble FLT, that transient period of high soluble FLT, caused irreversible damage that manifests itself way down the line. I really like that study. So I suspect that there's some long-term irreversible damage that's done. But it's conjecture, of course. The second question about, I think yes. I think Titan trunk. So first of all, no, I don't know of a dilated cardiomyopathy that has been rigorously tested, whether there's TTN Truncating variants, and shown there not to be. So as far as I could tell, it predisposes to all these. But that still begs the question of how does it do that, and how does that interact with a vasculotoxic agent? And if I knew that, then I hopefully could intervene on it. So I don't know if that totally answers your question, but
thanks.
There's something generic about it, yes, but still want to understand how it works.
Thank you, Dr. Muslehi. I have a couple more. I think we'll go a little bit over time because I think some of these questions are really great. Kirk asked in the peripartum cardiomyopathy patients, are there shifts in Titan isoforms or phosphorylation that you've seen?
Yeah, that's a great question. We haven't looked at phosphorylation very carefully. Well, first of all, it's very difficult to answer this question because we don't really have tissue on the cases of peripartum cardiomyopathy. We don't do biopsies anymore. It's a sort of an obvious diagnosis, so we don't need to do a biopsy. So it's rare, so we don't really have tissue, so I can't really answer this question. What I can tell you is the tissues that I do have, which are from transplant, post-transplant patients. And I can, so you can immediately make the caveat that, oh, that's a final common pathway. It's a burnt out heart. It doesn't tell you anything about how it started. And I accept that caveat. But the data are that there's no difference in splicing between peripartum cardiomyopathy or dilated cardiomyopathy with a variant versus without a variant, without a Titan variant. There's no splicing differences as far as we can see. In fact, there's no splicing differences even with a non-failing heart, strikingly, surprisingly.
Great. I think one
and
of
the phosphorylation, I don't know. We haven't looked.
I think one of the last questions we'll take is from one of our fellows, Shannon Walker. She says, what genetic studies, if any, have been done in the areas with high burden, such as in Haiti or in Nigeria? And are any of those linked to Titan variants or any genetics of Americans or of African descent? Yeah,
as far as I know, there have been no genetic studies in those groups. And I'd love to do them. If you know of a way to, I've tried to reach out. It hasn't happened yet. If you can facilitate that, I'm all over it. We'd love to do that. Yeah.
Well, thank you so much, Dr. Arany, and thank you everyone for attending today. This was a wonderful conversation. Hopefully next time we can have you here in person. Luckily, you missed the rain today, so it's not like you're missing great California.
Oh, that's funny because it's 80 degrees here. That's how about that?
We should swap spots.
I'll move to Philadelphia. Yeah, how about that?
Well, have a great week.